So thank you very much for this invitation. I'm Arnon Kater from the Amsterdam University Medical Centers. And I'm very happy to also have here Paolo Ghia, the famous CLL doctor from Milan, but also from Boston nowadays. And we're going to discuss the more and more difficult part of relapse patients in CLL based on all the change we have seen in frontline disease. So let's start maybe, Paolo, with the guidelines. We are slowly but surely, specifically in Europe, moving from continuous treatment in frontline to fixed duration treatments. How much does that affect your choice of the patients in relapse?
Yeah, no, thank you, Arnon. I think that the first point that we have to make, that is true also in the relapsed refractory setting, is that there is no more space for immunochemotherapy if there is access to novel therapies. And that was already true in the previous version of the guidelines, and it is definitely now very clear in the current guidelines. And in fact, the only option that we find is, as you mentioned, either continuous therapies or fixed duration treatment. In the relapsed refractory setting, it is, of course, a little bit easier to decide what treatment to do because the patient already received a prior treatment, and therefore your options are decreasing. And very likely, if the patient received a continuous treatment, the patient became resistant, then the obvious option remains the fixed duration treatment with typically combination with the venetoclax plus rituximab, because the continuous treatment is typically based on a BTK inhibitor. If the opposite happens, so if patient relapses after a fixed duration treatment in frontline, then there we have many more options that we may discuss in details later on, because indeed one could really retreat the patient with fixed duration treatment, though it really depends on the local regulation and the possibility of access of retreatment with the fixed duration combination. Or you have always, of course, the option of moving towards continuous treatment with the BTK inhibitor, for example.
And now, good that you mentioned this, because if you now, in most countries, I think you have the two regimens probably most effective for first-line patients. If you want to go for fixed duration, is ven plus ibrutinib, maybe soon acalabrutinib, and venetoclax plus obinutuzumab. And then in second line, if you want to go again for a finite treatment, the only option you have is venetoclax rituximab. Is because of that landscape, is that for you a reason to choose maybe one or the other in the first line, so you have more chance for long remissions in second line? Or you think it's independent of your first line choice?
Oh, that's very true. It is also true that you can use the finite treatment with venetoclax plus rituximab in second line, regardless what you started with.
Yeah.
And so that is probably not really changing so much my attitude towards either one or the other. So I would decide to treat based on as explained by Dr. Eiskorst, Shu, and Scarfo in another filming. In frontline, you choose based on many other features that typically don't consider so much what is going to happen in the second line, because indeed, even if you start with I plus V or with venetoclax plus obinutuzumab, then you can always decide to use venetoclax plus rituximab, or you can instead decide to go for continuous treatment. And that probably depends on how the patient responded in frontline, how well tolerated venetoclax and the antibodies, and so on and so forth. Yeah. So you will learn much more during the first treatment so that you can probably adapt your choice in the second line.
Yeah, and added to that, me, and Eric have very much always emphasized that every line of treatment, it deserves to do p53, del-17p, maybe also complex karyotype. It's still debating. But with all the new targeted agents, how differently would you decide if a patient has a TP53 at relapse than if he doesn't have it? How does that impact your decision?
That is very true. Of course, again, the patients with p53 aberration that tend to increase in terms of frequency in the relapsed refractory setting, at least after the immunochemotherapy, are definitely the patients on which we typically pay and put more attention. In general, we all believe, starting from the front line, that continuous treatment is probably the best option, or the one that where we feel safer in terms of having control and keeping control, maintaining control for a long time. It is also true that under continuous treatment with a patient with p53, when the patient relapses, is really becoming refractory to that treatment, so you cannot reutilize it anymore, typically the BTK inhibitor. So you are either way then obliged to use a venetoclax-based treatment, and definitely a finite treatment with venetoclax plus rituximab. You can also use continuous venetoclax, but still there is no really proof that there is an advantage compared to the fixed duration. And we also know that patient, based on the Murano study, though that population was mainly pre-treated with, the vast majority were pre-treated with immunochemotherapy, we know in that particular population that at the relapse, when patients they are treated with venetoclax plus rituximab, the patients who are relapsing earlier with a shorter progression-free survival are indeed those with aberrations in the p53 gene.
Yeah, no, true. And do you think, besides p53, maybe as relevant or more relevant could be that we put in guidelines that you also have to check for BTK mutations if you have continuous treatment, but maybe also after final treatment of BTK inhibitors, we say the evidence is too low, it's still research, BTK mutations?
No, in fact, thank you for the question. There will be soon the recommendation published new recommendation published by Eric for the first time on the use of mutations in the context of targeted therapy. So not only BTK mutation, PLC gamma 2 mutation that can occur after treatment with BTK inhibitors, but also the BCL2 mutation that can occur after treatment with venetoclax. And definitely, we do recommend not to perform the analysis because it's not really adding much to the management of our patients, because even if there is a mutation and there is still a clinical response, we should continue the therapy, and we definitely should not switch to another treatment. There is no proof, there is no data that could be of any value for the patient. And also, we have to keep in mind that many patients, a proportion of patients, will relapse without developing mutations in BTK, PLC gamma 2, or BCL2. So the role of these mutations remain very still very elusive, and in particular, it doesn't have any strong clinical implication at the moment.
Yeah, so keep it more for research. You say it's to know, but we have to do it in trials. That at least in
definitely, we have to learn also learn how this may be different depending on the inhibitor. How we can potentially in the future sequence the different inhibitors, but that really remains research.
Yeah, and then there was always in the guidelines this distinction between if you relapse, short remission duration or long remission duration. But that's maybe also more chemo-immunotherapy related, but you also said maybe fixed duration. Do you still, what is the cutoff? It has been 24 months, it has been 36 months, it has been longer even for some therapies. What do you think?
Well, this is a $1 million question, meaning that indeed it could be 24 months, 36 months. There is really no strong data, if not in the setting of immunochemotherapy, showing what is the right time when to consider someone refractory to the disease, even if the patient initially responded but then progressed. If it progresses in a shorter time, we still consider that as a refractory patient to the previous treatment. That is something that we have still to understand in the era of limited treatment, of finite treatment, because again, it is definitely true that it's better to relapse later than earlier, of course, even after venetoclax plus obinutuzumab or ibrutinib plus venetoclax. But the 36 months is anyhow quite some time, meaning it would mean 1 year of treatment, for example, with venetoclax plus obinutuzumab, followed by 2 years before the relapse. And plus, we have always to consider that in CLL, you have also the time to next treatment. So we have another period, extra month, where the patient will not need yet treatment, though progressing. And knowing that all these drugs and all these combinations are very well tolerated, definitely much better than the chemoimmunotherapy, I always think that it doesn't cost much to try again, because maybe you gain another only few months. You might say this is a failure, but in the overall patient journey, that's still a success, because we are postponing the passage, the shift to another really different class of drugs. So we really exploit and optimize at maximum the use of that particular drug. So this is the general, it's not written in the guidelines, but it's my personal interpretation. But the general feeling is really that it's difficult to evaluate when it is too early, when it is too late, and probably it's worth to try and see.
Although you also have got data from Jennifer Boya, for instance, that if you switch the drug, that maybe the clone that appeared also can disappear again. So, but it's all good reasons.
Again, also that is research. It's a very attractive possibility, but we don't really know. And I think it's in that case we would really be betting on each single patient, which we probably don't want, because at the end, are we then losing another, wasting somehow another line of treatment too early? So that's also the concern of a patient, because definitely a patient who relapses after the first treatment with the novel therapy is anyhow a more difficult patient to be treated in the future, that we know. For pre-existing condition or because of the effect of the therapy, but it's definitely much more difficult. So we have really to be very careful in optimizing the use of any drugs that is left over.
Thank you for the bridge, because that brings me not so much time anymore. We mostly discuss now first relapse, but in my clinic, and I'm very sure you see that too. You see more and more patients with at least double exposed, and also actually more double refractory disease. And for double refractory, we define as both BTK exposed and refractory, and venetoclax refractory. Although, as Paolo said, it's very difficult to have a good definition for that. But with those patients, what is now your current treatment outside clinical trials? What do you do?
Yeah, here in the current guidelines, we were already somehow looking into the future, because we added the non-covalent BTKI as a possibility of treatment, an option for patient progressing on a previous covalent BTKI. And actually there we made a small mistake, because we didn't list the non-covalent BTKI in patients who were relapsed refractory, who carry p53 mutation or deletion 17p. So it looks like we don't advise to use the non-covalent BTKI, which is absolutely wrong, because we know that the non-covalent BTKI, in particular Pirtobrutinib, which is the first one that has been very recently approved also in the European community. It has already been approved in the US since a few months. So that works after Pirtobrutinib, non-covalent BTKI. It works after failing, becoming refractory to covalent BTKI. So that is, we know from the original study, both the phase 1 and the phase 3, that it works also very effectively after in the setting that you mentioned, so in patients with double refractory disease, so failing both the BTKI, covalent BTKI, and venetoclax. And therefore, that is definitely the option for the patient who now will come to our offices, to our hospital with the double refractory disease. But the approval, for example, in Europe, has been after only the failure of a covalent BTKI. So that is something that we will learn by doing, very likely, because, of course, we will be using now, very likely, Pirtobrutinib earlier than what we were used in the past, based also on the phase 1 study. So we were using it in the single refractory patient. So it will be interesting also to see how and for how long the treatment with venetoclax after 2 BTKIs will really which type of efficacy will have.
And after that, or maybe if the patient is responding to Pirtobrutinib, what would be the moment, if at all, you would consider patients when you're in the US for CAR T, in Europe maybe for an allo transplant, if he or she is eligible, of course? Is that we do it after, during Pirtobrutinib plateau, or after? How do you see this?
That is tough. So that is probably one of the reasoning that one should keep in mind, thinking about the sequencing of the drug. So that is probably the setting. If I have a young patient, in particular, maybe someone with P53 aberration, in a patient where probably I would exhaust the BTKI option first, so covalent and non-covalent, because there we never, or very rarely, can reach a deep response as we want to go to for allotransplant. And then we leave venetoclax as the last option, because with venetoclax, still in a proportion of patients, we will get very deep responses. So the best setting to do the allotransplant. So using venetoclax too early would mean also to anticipate earlier the allotransplant, which remains, in my mind, always somehow not the last resource, but definitely a more advanced resource, because we are talking anyhow about a young patient where we can definitely control disease for a few years, and we don't want to expose them to the risk of treatment-related death, as it can happen, unfortunately, with allotransplant.
Do you give CAR T cells, and to what patients then do you reserve that for?
Even in the US, the use of CAR T remains still a very limited option, meaning that in CLL, there are so many different drugs approved, and Pirtobrutinib was already approved earlier in the US, that somehow CAR T replaces somehow the space that where in Europe we would do allotransplant. And due to the cost, and therefore also problem of access, depending on the insurance, so very, very often, probably the option of a clinical trial remains probably the most viable option for the specific patient.
Yeah, very good. So I think we covered most of the challenges that we have now, but also all the opportunities for relapsed refractory patients. Do you have anything else that we didn't cover, Paolo?
I think that we have to be optimistic, because, again, talking now about allotransplant or CAR T, I think that we have another generation of drugs that are coming to CLL in the relapsed refractory setting, in particular, in the double refractory, and now probably in the triple refractory setting. And I'm talking about the BTK degrader or the bispecific that, as you well know, they showed really a high level of efficacy with, again, oral therapy, like in the case of BTK degrader, or anyhow just a small infusion, or even subcutaneous for the bispecific. So much easier also in terms of management and logistics for the patient.
Yeah, I fully agree. Yeah, and you think how many years are we before we don't need to discuss relapse refractory anymore, because we can cure them in the first line?
Well, that you have to ask our British friends. I don't really know. I think that for many years we will still treat and retreat the patient. Most of our patients, in some probably we will reach a level at least of a functional cure, so they will have only one treatment in their life. By most patients, we will probably keep on doing this treatment and retreatment. In particular, probably we will optimize even the length of the treatment in frontline, which is not only to extend it, searching for cure, but to reduce it in order to maintain the response also for later lines.
I agree. To really make CLL like a chronic disease, a more chronic condition with some diseases that you have to treat, and then long-term good outcome. Yeah. Thank you very much. I think we can